everybody, and welcome to this online event looking at developing a safe and supportive environment where staff can deliver high quality care. Thank you so much for spending your lunchtime with us today. I'm Ruth Robertson. I'm a senior fellow here at the King's Fund, and I'm going to be chairing the event today. You might have been expecting to see my colleague Shilpa Ross, but unfortunately, she's been struck down with COVID. So I'm stepping in today and really pleased to be here for this, what looks like it's going to be a really interesting and important conversation. Before we get started, I'd like to thank our event sponsor. The event today has been sponsored and funded by Spire Healthcare. We have a really great panel of speakers here to talk to you today, and they represent a whole range of perspectives. And we've also got a really great audience for the event. I've just had a look online before coming to start the event, and there are over 2,000 people registered today, a really wide variety of organisations that people are representing or perspectives that the audience are bringing, NHS commissioners, charities, different types of health and care providers and patient representatives. So it's great to have you all here today, and hopefully that bodes very well for the questions and the variety of questions that should come in later in the event. Let me just say a few words about how the session is going to work. This online event is live, which might be demonstrated if you can hear a beeping behind me. I'm not sure if you can, but it's just come in the background. So any mishaps will be broadcast to you live this lunchtime. And the panel, we're going to start with a panel discussion, which will be followed with a live Q&A, which is always a brilliant part of these events. Let me encourage you to submit your questions. There is a box on the right-hand side of the video where you can both submit a question and you can also vote on the questions you think are most interesting. And I'm going to, after we hear for initial conversation for about 40 minutes with the panel, I'll move over to the Q&A, and I will try and pose as many of the highly voted questions as I can. So do submit your questions and vote on the ones you're interested in. There are already questions coming through even before we started the event today, so that's fantastic. You're also going to see some polls, some survey questions pop up, so please do take a moment to answer them as well. And I'd like to encourage you to follow the conversation on Twitter or X. We're using the hashtag KFOnline. That's KF for King's Fund Online. So take a look if you're an X user. Final thing is we recommend you look at the resources page. There's loads on there. If you go onto the left-hand side, there's of the screen, there's a menu with a series of options, and you can navigate to the resources page. So if you want to think more about this after this topic, after the conversation today, there are lots of great resources to help you there. Okay, that's enough of an introduction from me. Let me briefly ask the panel to each introduce themselves before we go on to the main discussion. So I'm just going to bring people in as they appear clockwise on my screen. I'll start with Dr. Ho.
Hi, my name is Tim Ho. I'm the Chief Medical Officer at Frimley Health. I'm a consultant chest physician when I'm not being a Chief Medical Officer.
Thank you so much. Justin?
Hello, I'm Justin Ash. I'm Chief Executive of Spire Healthcare. We're the largest independent healthcare provider in the UK and a public company.
Wonderful. Aidan?
Hi, good afternoon, everyone. I'm Aidan Fowler. I'm National Director of Patient Safety in NHS England.
And Melissa?
Good afternoon, thank you. My name is Melissa, and I am here by a patient of experience after my son died of sepsis 10 years ago. So I work alongside the Sepsis Trust to raise awareness of that, but also work on patient safety nationally.
Thank you so much for joining us today. Let's move on to the main event. And I want to start by asking a question about the state we're in, the current situation. Let's start where we're at. Where do you think we are in terms of developing a safe and supportive environment where staff can really deliver high quality patient care? What's the kind of current sit rep? And I'd like to start with I guess, a bit of a national perspective by coming to Aidan.
Thanks very much, Ruth. So I think I'd start, as you would expect, by talking about our National Patient Safety Strategy. So we published that 5 years ago, which seems an enormous amount of time now because there's a lot gone on. We published it 6 months before the COVID pandemic. Nevertheless, I think we've done quite a lot. And the important point, and some people will be familiar with it, some people less so. The important point was that whilst we talked about how we learn in our insights piece, how we structure safety in the involvement piece, and how we improve, make the change necessary, the whole thing was underpinned by the idea of systems thinking, not going to individual blame and so on, but also culture. And everything, every part of that, we think about the culture of organizations, how they work, how people feel safe, how we create safe systems for them. And some examples of that, I mean, we've had a Just Culture guide for a while, which is being renewed at the moment because it's a little outdated. But I think important developments, things like what we call PSIRF, we're not great on acronyms, I've often said, the Patient Safety Incident Response Framework, which replaces the Serious Incident Framework, completely changes our thinking about how we investigate where issues occur and how we support staff in those circumstances, as well as, importantly, patients and families. And that's been a really popular thing, which we've now implemented across the system. As well as then going on to report that online. And I think as evidence, you know, we often hear people don't feel safe to speak up. And of course we work on that. And there's a lot going on freedom to speak up and the work around that. But importantly, we upload about 2.4 million incidents each year, 3/4 of which are no harm data. So people are feeling able to report and to speak up and let us know of issues. So they're reporting locally, we're picking that up, and that's happening 2.4 million times a year. And as I say, a lot of that is where no harm's occurred, but people are bringing that to our attention. So that again, I think is really encouraging, and that enables us to learn the themes of what's going on. And in addition, just on the, you know, we have Melissa with us, the ability for patients and families to speak up will be enhanced by the introduction of Martha's Rule, which I'm sure people have heard about, so that in that moment of concern where people are worried about deterioration of a relative or indeed themselves, they will be able to pick up the phone and call for someone to come and see them. So again, we're trying to enable and empower people's ability to speak up when they're concerned. So I think a lot going on, but I accept that the strategy is now 5 years old and we have a new government, and you know, it's timely that we go back around the loop on that and say, yes, we have a great platform to take off from. There are still concerns. There's still a lot of work to do. Where next, and what's the direction for that?
Thank you so much, Aidan. So some important national initiatives on reporting. Let me now come to Justin. How does it feel within your Spire providers?
Thank you. The reason why we were so keen to sponsor this discussion is it is clearly the most important discussion in healthcare, because if people aren't safe, nothing else follows. I think Spire is now, we're not complacent, but in a very good place on this. Why is that? And what is the one message that I would impart about what we have done and what I think needs to happen? Which is, this has to be the #1 priority for everybody throughout leadership in healthcare. And I do mean #1 priority, as in, if there is a situation where healthcare isn't safe and colleagues don't feel supportive, you really can achieve nothing else in your healthcare environment. So we are enthusiastic about a number of the initiatives that Aidan's talked about. Just Culture, Freedom to Speak Out Guardians, he's talked about the Patient Safety Initiative, and Martha's Rule, which we've rolled out. And these are all really good tools and programs. However, if you have a list of things to do and you hand them over to somebody to implement those whilst getting on with what you think is your day job, you will not have a safe and supportive culture for quality. And it has in particular been my personal mission in the 7 years I've been here to prioritize this. And just to give you an example of prioritization, in the early days, we discovered that a number of our consultants hadn't completed their annual appraisals. They hadn't told us whether or not they were appropriately registered. So on the day we discovered that, we suspended hundreds of consultants and they couldn't practice till they'd done it. So that totally disrupted the hospitals. It's a terrible thing to do if you're running what is a public business. But it really got the message across that safety and quality is the heart of what we do. And I think as a consequence of focusing on quality and safety, we have a really engaged workforce. And I can give you the statistics of how engaged they are. 83% proud to work for Spire. Over 90% know who their Freedom to Speak Up Guardian is. I personally sponsor Freedom to Speak Up Guardians, meet with them every time I go to a hospital. And I rarely talk about the numbers when I do a visit. And we try to work this through all of our leaders. So I think we're in a good place, but we're in a good place because we made a conscious decision that everything else is subsidiary to this. And I think our people do believe that. And you do have to go through this sort of radical upending of what really matters in healthcare in order to achieve the results you want. And I would say all the way through to elective recovery. You really can't have elective recovery if you've got a hospital or a ward or a theatre where the staff don't feel safe. So you really do have to start here. So I think there's lots of good things happening. And I think agents programs, we've just adopted them and run with them, but we've run with them in a way that everybody knows their priority. And I'm sure we'll talk about them more in the future. But so I'm feeling positive. I'm feeling we have a very engaged workforce. In fact, I was in a hospital in Liverpool yesterday where a couple of staff members came up to me and said, you know, a few years ago, if we spoke up, we felt we were in trouble. And now I can come along, I can raise a concern, I get thanked for it, and I feel like it makes a difference. And that is, I think, what we're aiming for in healthcare overall. And I'm optimistic that we can make further progress.
Thank you so much, Justin. And so interesting to hear, you know, these processes that can often feel like part of the drudge and kind of feeding the beast, and what you did at Spire to kind of show their critical importance as part of quality and safety, to kind of go through these appraisals and make sure people are delivering safe quality care. Let me bring in Tim now. I wonder how things feel within the NHS and at Frimley.
Thanks very much. It's quite interesting. I think both Aidan and Justin have touched upon points I was going to make. I would say, again, well, you think you've got things lit to some extent. You think you've got a good culture, but actually, it's a continuous process. It's, I suppose, like painting the fourth bridge when they used to have to paint the fourth bridge. It's about trying to get staff to keep focusing on what's important. I think the big change for us, I think, is PSERF. And that has certainly changed the focus on how we look into incidents. I think when incidents are looked at, people who've never been in that situation before feel quite anxious. And the good thing about PSERF is about the learning and the genuine focus on that, rather than trying to ascribe a label such as an SI or a never event. So that's been a real change for us. It does cause some confusion because a lot of our clinicians have to appear in front of Majesty's coroner, and the coroner sometimes looks at things in a different way. And so part of the supportive strategy is actually making sure that people, in whichever environment they have to talk about events and issues, feel that the organisation is behind them. And that also sings to the just culture piece as well, because I think people have always felt that raising a concern historically could somehow lead them into trouble. I mean, Justin's mentioned that earlier, and it's something that we work very hard on to make people feel that raising an issue or flagging something is important. Clearly, the NHS is going through a tricky moment. I think if in the NHS money is tricky, despite what's been put in, I think the period after the pandemic with elective recovery has stressed the system and the waiting list. And so people, for me in particular, in our organisation, we want people to actually sing up if they've got concerns, particularly as waiting lists have increased. and also through the period of industrial action, which has made some issues and relationships more tricky to navigate. But the key of it is actually trying to keep reinforcing that this is about a patient and trying to do the very best for patients. And sometimes you have to ante up. You have to show that by committing to how we staff, how we recognize when there's staffing issues. I think staffing has been an issue. And now that we're in a more financially constrained position, to making sure that we still focus on quality. And that's one of the challenges. I think it's a cyclical event. So I think you've been in the health service long enough. I think people recognize that. So it's that reiteration about what we do. And I do think that NHS England, having thought about safety again, Aidan's work in particular, I think has really made a difference, because I think that has put a different focus. The key is actually disseminating it and making sure that people think that it's realistic and a real change that we're trying to enact.
Thank you so much, Tim. And you highlighted there that all of this work on safety and quality is in service of patients. And I'd like to bring in Melissa. Can we get your perspective about how things feel right now?
Thanks, Ruth. Yeah, I think you've hit the nail on the head, really. This is about the patients, and the patients have to be at the centre of everything that we do. And regardless of the wider challenges that the NHS or healthcare professionals face, we as patients only interact with healthcare, certainly in an acute setting, when we are at our most vulnerable. And we have to treat patients with kindness, with compassion, and with respect. And I think it's the age-old adage of the British public. They don't like to cause anyone any worry. They don't like to be bothersome. And I think there's a lot of times where we don't like to speak up because we don't want to be a nuisance. But I think there's a real difference between feeling safe and being safe. And we can only be safe in an environment where our healthcare professionals are safe. And I think it's really, really important to make sure that we are very protective of their psychological needs as well, because our patients will only be safe when our staff are safe as well. And I think Justin hit the nail on the head when he said that, you know, when he established that his consultants hadn't had their appraisals, that they were promptly suspended. And you know, we have to lead by example, and that's leading by example. And I just think that's so important. We mustn't forget the patient at the centre of everything that we do, but also to ensure that our healthcare professionals are safe too, because they will only be able to deliver safe care when they feel safe too. I think the framework, the PISA framework that has been put in place, I was a product of the previous serious incident framework. And I can tell you that that was the worst 2.5 years of my life. And to have had some experience of PSERF now and been involved in some of that process, it's like night and day. And I think keeping, you know, when things ultimately do go wrong in healthcare, and they will go wrong, it's making sure that we do the right thing, that we speak up, that we're open, we're honest, we're transparent, and keeping the families involved as much as they would like to be, I think is really, really important as well.
Thank you so much, Melissa, and such a powerful message there. I've just written it down about patients are only safe when staff feel safe. It just feels like such an important guiding principle in this conversation. Let's move on now. We've talked about the state we're in. Let's move on to talk about the change we want to see. And I want to ask the panel where we need to make changes and be more proactive to support staff to deliver high quality care. And I'd like to start with this question. Let me start with you, Justin.
Thank you. And let me build on what Melissa so correctly said. This is about how you put patients at the centre of what you do genuinely, but you can't do it unless staff feel safe. So let's start with staff feel safe. Staff don't feel safe if you haven't got the right staffing levels, by the way. So it's very hard to move forward on patient safety if staff feel they don't have the right staffing levels. And I think this will be a subject of much debate in the NHS. And again, it's a few years ago now, we asked staff and we looked at staffing tools and they said they didn't feel safe. So we materially increased our staffing levels. In fact, I had to do what's called a profits ruling, which was very painful. But it wasn't as painful as thinking that our staff felt unsafe with staffing levels. So there is some practical stuff here, which is this isn't just words. You may have to change things in order for staff to feel safe. When it comes to speaking up, we monitor all freedom to speak up. And every week, I and my management team look at anonymously concerns which have been raised. And most of those are being dealt with appropriately. But if we feel there's something thematic in a site or a hospital or a clinic, then we have our own freedom to speak up leader who will go in and talk to staff. So again, you come back to, it really does have to be on the top of the list of leaders in order to make staff feel safe. Then you come to how do you listen to patients? And I think having been a patient myself, Melissa makes a key point. Patients are vulnerable. They may not be behaving in the way that they would normally behave. They may not feel they have as much agency as they would normally have in life. So giving staff the license to care. So I've got 4 strategic priorities. 2 of them are listen up, which goes to that feeling safe, and inspire kindness. And I think kind organizations, which are kind to their staff, are also much more likely to think that being kind to patients matters. So culturally labeling kindness as important. We've rolled out our version of Martha's Law. We've called it Ask to Escalate. And really what that is a label that tells patients and staff, include patients and their families on the journey. So things go wrong. We had a difficult learning. We had a learning where at night we had a patient who deteriorated and the family did not feel sufficiently included. They didn't know what was going on. So in response to that, we've added an extra staff member at night whose job is, if needed, to be family liaison, to give one person the time to speak with patients' families. Because quite often when things go wrong or there's a difficult situation, everyone's focused on the patient, but actually the family is often the group that need and are important to have communication with, and they know what's in the best interest often of their family member. And finally, PSERV, the acronym doesn't really do it justice. All it really means is if something goes wrong or can be learnt from, engage staff and patients and their families immediately in a very low bureaucracy way in talking about what happens, what can we learn from it quickly, how can we improve, as opposed to long processes which have a slightly legal bias towards who's responsible. In the end, it's about running a human organization. These are all ways of running a human organization that cares. So those are the sorts of things we can do and I think can be done.
Thank you so much, Justin. And I love the focus on kindness in your comments just then. Let me now bring in Aidan.
Thanks. There's so much here, isn't there? And we talk about vulnerability, and I've recently been the patient in a healthcare situation where I asked a question of a member of staff and they were very dismissive. And, you know, as a white male former surgeon who's National Director of Patient Safety, there are few people probably who should feel less empowered than I do in a healthcare setting. But I was also aware that I didn't want to adversely affect the care of my relative by getting into a dispute over something with a member of staff. So I do recognise that is a real concern and that kindness and respect are really important. And I think a lot of that is about what behaviours are tolerated within organisations. But I also recognise that the pressures on staff, and people talked about staffing, and you know, we need a system where the right staff with the right support, the right training, right environment, you know, buildings and otherwise with the right in-date, latest, best equipment, and working the right systems and pathways enables that comfort for staff, safety for staff that then impacts on patient care. And I think that's really important. And it's good to hear that PSERV has gone some way to addressing some of those things. And I genuinely think it has, and I didn't design it, so I think I can safely say that. I think there are a few things we need to do, and clearly we are in a different environment as of the last few weeks. And we have a new government that rightly come in and said, what is the state of the NHS at the moment and how can we improve it, and accept that improvement is still needed, and that's right. And so we expect a new plan for the NHS, and part of that will be a revised plan for safety, and I think that's to be encouraged. I have to be careful how I say this, because I recently said at Confed something about inquiries that got me a lot of trouble, because I got a bad headline in the HSJ. If you'd read the article, actually, it was a bit more balanced. But what I was trying to say there was about use of real data. I was not saying we should not have inquiries when they're necessary. And we've done a lot of work to try and improve those. So when there are big system failings, it is right that we go and look at that and learn from that, and that will involve a much bigger thing than PSERV can offer. So I was not at any point suggesting that there should not be inquiries into failings in that way. And as I say, we've done work to try and make sure when that's necessary, it's set up in the right way. And I think, recent report on Greater Manchester under our new framework was a good demonstration of how that can be done in a timely way, and with proper engagement of families and so on. But what I was saying was that we need to try not to end up in this situation by noticing data in real time. And if you look at some of these system failings, people are trying to tell us what's going on, and those people are patients and families, as Melissa said, and staff. And when they're heard, and I accept, and leadership, when we talk to them, are very engaged in this agenda, but what they will say is they are trying to sort out signal and noise. And I understand that, but we have to listen to that voice. And what I think from looking at lots and lots of these incident data is that the voice of the patient and families and staff is what you hear first. Actually, it leads the sort of outcome data that indicate there are problems. So we've got to be able to work in real time with those data, and that's complex and it's not straightforward, but we've got to get better at it, and we've got to have that curiosity. This is where I often quote Ted Lasso, if there are any fans, I'm sure there are, who during a darts game talks about, and actually he quotes Walt Whitman, who didn't ever say it, I gather, but the point is he talks about be curious, not judgmental. And I think too often people have been judgmental and not curious about what's going on. And that curiosity means leadership going out to the floor and seeing and hearing what's going on. And when people raise concerns, asking what's actually underlying it, and however presented, there's often a message in there that people need to hear. It's always really going to be difficult when the system's under pressure, and I think no more so than in UEC, where people are working very hard to improve UEC and get back on track with that. But that, I think, is an area I really want to focus on. I also accept that the narrative is sometimes unfair, and that's really challenging for staff. So no more so perhaps than in maternity, where there's been a really challenging narrative. And of course there is more to do in maternity, and we are doing things to improve maternity, but the data show that whilst things have perhaps tipped a little bit after COVID, are better than they were 10 years ago, but that's not what we hear. And we are not the worst in the world at all for maternity, far from it. And yet we have a very difficult narrative, which I think is really challenging for staff. It's also very challenging for our service users, who are frightened to come into a system that they've heard cannot look after them safely. And in the majority of cases, that's absolutely what staff do, is look after people safely. So I think we need a very honest narrative, but not a wholly negative narrative where staff are working really, really hard to improve, and indeed are doing so. So look, I'm expecting us to write a new strategy, and I'm expecting that to talk about how we look at data, to talk about how we learn from excellence, because there are some really good exemplars out there, and the focus on failure and concerns is important, but also the focus on where are people getting it right and how do we share that experience is really important. And I would expect us to be far more interested in the safety world in operations and flow than we perhaps have been in the past, while still paying attention to issues like healthcare associated infections, VTE and so on. And I think I can't speak for Lord Darzi, but I'm sure he will be looking at some of those so-called giants of patient safety, as well as access and patient experience in his report, and we will need to be able to respond to that appropriately. So
thank you so much, Aidan, and for sharing some of the wise words of Ted Lasso, which I think that series could be rebranded as a leadership development course if they wanted to market it in a different way. let me bring Melissa in now. What changes do you see are needed right now?
Thanks, Ruth. Yeah, I think it's difficult because as patients, when we are in an acute setting, certainly we are feeling vulnerable. We are also poorly. And when is the time that we can speak up? Because as we've touched upon here, there is staffing pressures, and we don't want to accept that as the status quo, but we have to be realistic. The only time that we have the ability to have that interaction with those that are our doctor or our consultant might be at the ward round in the morning. I can't impress upon anyone that is the worst time to be able to speak up and to say, I'm concerned, something's not right. You are laying in a bed, laying down with multiple people stood around you who you don't know, in an environment that you don't feel safe in. It's very, very overbearing. So what can we do to mitigate that? And the one thing that I wanted to impress upon was that my dad, he died in Spain of lung cancer, and he was in hospital for a number of months before he died. And my mum is retired, and my mum and the loved ones go into the hospitals, certainly in Spain, and they feed their loved ones, they help their loved ones go to the toilet, they help their loved ones shower, wash, convalesce. When we have children in hospital in England, the parents are usually with them, because there's nothing more safe and reassuring than having your loved one with you and be able to speak up. Now, I know that when my mum was looking after my dad, it freed up an awful lot of time for those nurses that would often have to go to him and change his bed, help him to the toilet, all of those, day-to-day hygiene issues. Why can't we involve our families and our patients more often? Why do we have protected meal times when our families can come in and help you to feed? I just think actually what we should be doing is enabling our public, not disabling them. And we need to include them more. And I think that would actually take the pressure off our healthcare professionals, who are somewhat burdened by, staffing levels.
Thank you so much, Melissa. And I have to say, everything you were saying there resonated with me in terms of personal experiences of healthcare and with family and the different roles we play. Finally, on this question, let me bring in Tim.
Well, I think that if the question is what change are we trying to do or still think we need to do, I think there is still quite a journey. I think it revolves around a number of things. One is a bit about just education. What are we actually trying to achieve? And it sounds like pretty common stuff, but I think people get stuck in a rut. I know consultants of a certain age have a view of patient safety and investigations and the sort of historical way that things have been transacted for the last 20 years. And I think it's getting people to think actually much more broadly and collegiately. And I think we use the term MDTs, but I really think that there's be a greater focus on actually working as a broad team, and that includes communication. So although I've spent the last 11 years as a medical director trying to work out how best to communicate, I think that needs to be reinvented, both for our staff, and I mean all staff groups, so doctors and nurses, allied healthcare professionals, but also I think with our doctors in training, or residents as I think they wish to be called, because I think the more we communicate, the more we try and actually explain why we try and do something, I think the better the outcome will be. And I sometimes worry that you can sit at the top of an organization and you understand, you've got time to reflect on all these things, but actually making sure that it's disseminated through the organization and the reasoning why, without having to use a stick and carrot mechanism of people getting to do things, which historically has been done in times gone by. The idea is actually trying to get people feeling safer, actually trying to work out what is the best thing, how we can actually get a better outcome for patients. Melissa's talked about involving families. I think that's a real key. a lot of the issues that we try and navigate and staff's feeling of safety or lack of safety is actually that how they interact with patients sometimes. You know, do they feel confident? Do they feel able to actually have that dialogue and actually working with patients, and as important their relatives, about how we go to that next step. I think that's critical, and I also think that the Freedom to Speak Up guidance internally, we're just having a review of that to try and broaden it. We've always had it as multi-professional, but actually getting more guardians. We run a number of acute sites and an elective centre, and to make sure there is that breadth of people that people can approach of different professional backgrounds. So it was led by a consultant neurologist, now led by a former nursing matron. But again, there are power dynamics there, and for me it's trying to make sure that people can actually approach someone they feel comfortable just talking, even if informally, about issues. So the more we can build this across the piece, I think that the better, and that requires a lot more communication, particularly as we also try and move through this sort of post-COVID recovery phase. I think that's been really key to us, to actually try and get staff working and trying to refocus on what remains the important elements, despite all the the winds of change swirling around the NHS. So for me, that's one of the key things I'm trying to work through. How do we message? How do we communicate? And how do we actually tell people these are the critical things, and actually listen to what from our staff, what are the critical messages? So I'm sort of assuming that I may know all the critical issues, but actually half it's working out what is really pertinent to different staff groups. And it'd be, I suppose, blinkered of me just to think, right, I've got it nailed. And I always assume that there's a big blind spot that I've got to try and unpick. And that's the sort of thinking that I've just been working through with some of my exec colleagues about how we take it to the next level. Moving through, changes of PSERV, and we've heard about Martha's Rule. Our organisation was very keen to adopt that, and I think actually the majority of NHS organisations were. And I think that actually sings to the point that staff do really want to do better for patients, and it's how we actually do that. And again, it's trying to work out, despite all the financial vagaries that we're navigating, can we actually deliver it? Because in the end, if you are seen to be doing the right thing, I think staff will come with you, and I think patients will recognise it.
Thank you so much. And I just think so often things come back to communication and relationships, don't they? And making those work in service of these goals. Now we've got one more question before I move to the Q&A, and I can see lots of questions are coming through, so do keep sending those through and voting on your top questions. But before I move to the Q&A, I'm going to ask for a bit of a quick fire injection of hope from our panel. We've talked a lot about the system being under stress, the various challenges at the moment, and in that context, where do you find hope? How can we continue to improve and build on what has come before? So I'd like to just go to the panel for a kind of minute response each, a kind of nugget of hope before I move over to the audience questions. And let me start this time with Melissa, please.
Sure, thanks, Ruth. I come at this having 10 years down the line from losing my son. And when William died, they found 16 failings in his care and 4 missed opportunities to save his life. And one of those was the very last doctor that we saw, where his examination was substandard. Even the basic observations weren't taken. And if they had, he would have been sent to hospital without a doubt. The system that was in place at the time didn't allow me to talk to that doctor, created a them and us process. It didn't allow transparency. It didn't allow me to ask questions. And I had no choice but to go down a litigation route, which is one that I just simply did not want to take. I'm really encouraged now that we are really fostering safety and the involvement of families when things do go wrong. After the investigation was concluded, I asked to meet with the doctor. And I asked him how he was, because the previous 2.5, 3 years, he had undergone so much pressure, and his mental health was shot to pieces. But I didn't blame him. It wasn't his fault. He didn't send William home to die on purpose. He is human, and humans make mistakes. And I think what's really, really important is creating a safe environment for everyone to speak up and be together within that. So I'm really encouraged with the work that PSURF is doing, and, you know, fostering that psychological safety of our healthcare workers as well. I think we just need to continue to build on that, because I think that's going to really, really improve processes as well.
Thank you, Melissa, and thank you so much for sharing your and William's experience. I can't imagine that ever is easy to share, no matter how many times you talk about it. Let me move on to bring Justin in. Kind of a minute from you on where we should be looking for hope.
Okay. Well, I love to be positive, and I love hope. And I guess the big hope is you can change things. So 6 years ago, as a benchmark, for instance, Spire, only 2/3 of its sites were good, one outstanding. All our inspections have been good or outstanding the last 5 years. We've now only got one site which hasn't been inspected. All the rest are good or outstanding. You can change things. 5 years ago, there weren't any freedom to speak up guardians. Now, 93% of colleagues know who their freedom to speak up guardian is, and they're happy to speak up. I think the biggest source of hope is the healthcare workforce is absolutely wonderful. They're wonderful people who are working very hard and need supporting and are highly qualified. And I go around sites, and every day I'm given examples of compassion, patient focus. We celebrate them, we have awards for them. So I think the resource is there to crack this. And if you can unleash it, and not everybody here, by the way, are healthcare providers. Of the 2,000 registered, many aren't in healthcare. This is about psychological safety. This is about unleashing the potential of your workforce by focusing on patients or customers, whichever you call them. And we have this brilliant resource. They work for us. And if you give them the power to do so, they will create a wonderful, caring environment. So I think there's lots of hope if you focus on it.
Thank you so much, Justin. Aidan.
Look, we've come out of a really difficult phase of going through a pandemic, both during and after. It's been really tough for our patient population. It's been really tough for staff. We have built a lot during that time. We've built a real platform for improvement on safety. We've got workforce plans, we've got all sorts. And I've been really encouraged by massively engaged conversations with the leadership across the NHS. And we've got a period of refresh now where I'm having really, really engaged conversations across the system, both politics and otherwise, about moving on, taking next steps, recovering. And I think we can do that, and we've done it before. So I'm much more positive than I would have been perhaps a year ago about it all.
Thank you so much. Finally, Tim, what makes you hopeful?
I think it's the enthusiasm of the staff. I think that's the one thing I've noticed. I've mentioned PSURF several times, but it's the clinicians who I work with, and we have a patient safety team, but actually across the piece. And actually, when there was a call for Martha's Rule, its introduction, I didn't have to go and ask anybody. Actually, I had people coming to me in person, and actually approaching by email, saying they want to be part of that first wave. So despite everything, people are really keen to do something positive, which is patient-centered, and I didn't have to do anything about that. You know, people have really driven that. So at the heart of it, it gave me a lot of hope that people still want to do the right thing and actually improve the system we're working in.
Thank you so much, Tim. I'm now going to open us up for questions, and I've been looking at the popular questions. I'm going to try and group a few of them together because there are a few coming through on similar topics. But let me start with a question I'm going to direct towards the kind of healthcare provider representatives here. The top rated question is coming from Winnie Leong. I hope I've pronounced that correctly. And she's looking for some tips on how to hold conversations with senior management and to get them to recognise the importance of creating that kind of safe working environment. She's highlighting things like check-in sessions and just ensuring staff have a moment to kind of breathe and reflect. I wonder, Justin, if I could start with you. It sounds like this is something that you are focused on, but how do people get senior management to open up and be interested in this topic?
It's such a good question. It is the question, I guess. So first of all, it really matters who your senior management are. So for instance, we've got 40 hospitals. I personally interview every person who's likely to be a hospital director, because you have to pick the right leaders. And to pick up a point that Aidan said, the most important leadership characteristic in healthcare, in my opinion, is visibility and curiosity. Being able to ask questions in such a way that you find answers. So when I go around hospitals and in meetings with senior management, I enable them to have time with me to ask open questions. I also, by the way, meet with all the staff without management, just to ask them how it's going. So I think just a little bit of people knowing that you're not always there as part of management, but you're also on their side. I think the toughest area for management, actually, once you've got the right leadership, isn't people like me. It's heads of department who are actually every day working hard with lots of other pressures. So supporting them to listen. One resource I really recommend people to, the Guardian's Office has 3 super modules. Speak up, listen up, follow up. Those are management training for all our managers. They're really super modules about how in simple ways you can create the time and respond positively to listening up. So there's a starting guide, as long as making sure you have the right leaders in place. I do recommend that resource. So a few thoughts there, but I consider leadership development and capability, along with culture, the key enabler that I focus on individually.
Thank you so much, Justin, and for the kind of practical examples of things that people can look at. Let me bring you in, Tim. I don't know if there's anything more you can say on this and how people within your trust would get your attention to these issues.
I would say waving and shouting, but we don't wave and shout that much. I mean, most executive teams wish to be visible at public board, but actually at town hall meetings. And most organisations usually have a forum for that. We do. We craft all staff briefings, exec listening events, and we have consultant briefings and junior briefings. So the key is trying to, as I think Justin says, make yourselves available. And at the heart of it, the exec team needs to be curious. I think you just have to know what is going on and just assume there is stuff going on, or be, not paranoid, but just think, is there stuff that I just need to know? Clearly, one's behavior, the culture about having that inclusivity and open door policy is key. And that's something that I think individuals need to work through. But it's the most powerful thing is when you hear it from staff, and we get the staff survey, but by the time that comes through, if that reflects poorly, then that's a very extreme way of signaling that. You want to know far earlier than waiting for the annual staff survey to actually point which way you should be going. So I absolutely agree. It's about making yourself available, and also making sure that people you work with are also conduits for which issues can be raised. And the important thing is being able, and to some extent, looking for painful truths. You want to hear stuff that you may not necessarily feel that comfortable, but actually the fact that people are able to raise that with you, I always think that's a healthy option. Obviously, I prefer if everything was perfect, but life isn't like that. It's the key is to make people want to tell you stuff that you can do better. It's that feeling we just want to improve.
Thank you so much, Tim. And I'm looking if Melissa or Aidan want to come in on this question, but if neither of them indicate that they do, I'm going to move on to a different topic. We've been talking about quality and safety, so I think it's natural that some questions have come in about the Care Quality Commission. There's a question here from Malcolm Philp. Has the CQC had its day in supporting quality within provider organisations, and should it be reformed, replaced, or other? What does the panel think? So I wonder if I might come maybe for a national perspective first, and I can see Aidan was perhaps expecting me to turn to him for some views on the CQC and their role in this, and whether there's anything you can say on whether changes are needed.
What I would actually say, rather than talking specifically, I mean, I will come on to CQC, I'm not going to dodge the question, but I am a great believer in the approach taken by Joseph Duran to quality. And for those who haven't come across him, he talked about it's a very simple structure, which is that in developing a quality system, and safety is a sort of overlapping part of quality, obviously, you need to think about how you plan for quality planning, how you assure that you've achieved what you're aiming to and stay there, quality assurance, and then how you make that change, quality improvement. Those are the three elements of quality. And an inspectorate is a key part of quality assurance. And I know some countries have said we don't need inspection, but we have a very complex healthcare environment, and we do have failings within systems at times. You know, the inspectorate is an important part of that. And you'll know, and plenty of our colleagues out there will know, that there have been multiple iterations of it. There's a current review going on of CQC. I think that's important. I think periodically it's good for all of us to stop, look, and see where we go next. And we wait with interest to see what that review suggests we can do to get better at it. But I think it's not an easy business. I mean, it's, you know, it's easy for us to say, oh, somebody missed this or somebody missed that. It's not an easy business. I think it's for all of us actually to take responsibility for that quality assurance piece and look at how we work best together to make sure that we don't miss things. That, again, looking at those complex data in real time and doing that in as efficient a way as possible. So let's see what the review suggests is the next step for any inspectorate. But you know, quality assurance is absolutely critical, and we need to just keep looking at how we get better at that.
Thank you so much, Aidan. I wonder, Melissa, I don't know if there's anything you want to come in on this one about the patient's perspective on having that quality and safety regulator there.
I think for us as patients, certainly before my son died, I looked at the NHS, and for me, it was just one. It was just the NHS. But then when something went wrong, I realised that it was completely siloed and things didn't talk to each other. And that sort of created a big problem. I think it is really important to have an inspectorate, but I think it's important to have, rather than, you know, rule with an iron fist of command and control, it's about empowerment, it's about enablement, it's about what we're doing with the guidance in order to help them. I mean, ultimately, I think as a lay person, we do see, oh goodness, you know, they're outstanding, that's fantastic, or, you know, requires improvement. And I think sometimes necessary, the messaging to the public isn't always right. It's why does it require improvement? What parts of it? Because actually there could be 80 brilliant things that organisation have done, but there could be a very small part of it that creates the problem. And I think it is about the messaging. It's about messaging to the public. It's about messaging to the people that work within that organisation, because I can't think of anything more demoralising than working your hardest that you can possibly be, and then you get a requires improvement from CQC. When you're doing your best every single day. So I think we do have to adapt, we have to evolve. And I think it is about it's about what we do with the guidance rather than focusing on the grade that we've been given. And it's doing the best that we can do, really.
Thank you so much, Melissa. I'm just looking to Tim and Justin to see whether they'd want to come in on this question. It looks like Justin's just gone off mute. So Justin, let me bring you in before I try and fit in a final question before we close. Justin.
So I don't know anything about where the review is going, but just a few observations. First of all, generally having an agreed standard of what quality is with the world-led domain, etc., I think is a strength of the UK health system. Because if you go around the world, you will find big debates about what is quality, what is safety, and then people rate themselves against their own standards. So I think the structure is something which is important. And Melissa's right. Patients really do choose where they go in our experience based on those ratings. So they need to be handled carefully. and it can be demoralizing for staff, but it could also be really important to signal that there are problems. So the general regime, we are hugely supportive of. And inspection matters. I mean, we have our own inspection team, along with building culture, to check that what we hope is happening is happening. That's an important part of healthcare. So I think the general existence of it, the importance of inspection, which is human and kind, by the way, so we reinforce the messages that we're putting through organizations really matters. So that's how what the review does, is build on the strengths and adapts to things which people think need to improve. But I think we should value the principle of what we've got.
Thank you so much, Justin. I'm going to move on now just to a final question. There's actually a group of different questions that have come in that are all on the topic of staff well-being. For example, how much of this should be the individual staff members' responsibility versus the responsibility of the system, how we get organisations to invest in evidence-based resources and approaches to help staff well-being, how we prevent burnout in staff within the current environment. I'm going to just go around the panel for a final word of whether there's anything you want to share on that question, or a final thing that you want people on this call to take away from the conversation today. So just a quick minute from each panelist before we finish. And I'll start with Tim, if that's okay.
I would say, very bluntly, making sure that staff, feel that you've got their back, that you know, when things go wrong, that's the quality of the leadership. How do you support people and patients through that? And I think that's really key. So that's my nugget in a nutshell, really, mixing my metaphors.
Thank you, Tim, and thank you for keeping to my strict requirements about short response. Let me go to Aidan next.
I've just come back from a 2-week holiday. It was the first one I'd had for a long time, and I realised I'd left it too long. And, it is very easy to just keep bashing on and not look after yourselves. But it's also the responsibility. I've worked in teams all my career, and the support of that team is critical, and the support to the team is critical, and no less so as I work in a sort of office environment now, making sure people are not overloaded, they're not expected to do too much, being aware of what's going on with them. So one of the things I always want to be told when something critical is happening to a team member, it's that knowledge of the team, and a little bit of insight into their outside world as well is really important. And it requires you to actively think about that and work on it, but have your team's back and they'll have yours, and make sure that you work with other people who have the same ethos, I think, if at all possible.
Thank you so much, Aidan. Justin.
So I'm so enthusiastic about the topic of colleague well-being, and this goes much wider than healthcare. We have an occupational health business, and I think employers, and I think this government, are very alive to the fact that employers have a real responsibility for their staff well-being. And simply put, mental health, physical health, culture, colleague support, this is the upcoming agenda. And if you have happy colleagues in a kind environment, you will just have a better organization, not least of which will be in the delivery of healthcare. So I think this is a whole topic in itself. It's part of this agenda. And I think we're going to see much more employer responsibility and much more active support for employees going forward. I certainly hope that's the case. And I think my key message from all this is my starting message. This topic is the number one topic. It's all about creating a culture which is led from the various bits of the top. And if you make it your top priority, some very, very good and wonderful things will happen in your organizations, who will then focus on their patients.
Thank you so much, Justin. And as we wait for the clock to flick over to 1, I'll just come to Melissa for the final word from you.
No pressure.
Sorry.
I think for me, the key message here is we have to listen and we have to observe. I think that senior leaders have to listen to their workforce. I think The workforce have to listen to the patients. I think without listening, we can't really learn. And I think where people do feel afraid to speak up, we must be observant, because as Aidan just mentioned, they're having a holiday when he should have had one before. Before they reach burnout, we must step in. So we have to be observant as well, and that's that curiosity. So listen and observe for me. Thank you.
Thank you so much, Melissa, and thank you to all of the speakers and the audience today for all of your brilliant questions. We've run out of time, I'm afraid. We could have kept going for hours, I think, with all of the questions we've had from the audience. I'm left with your words ringing around my head, actually, Melissa, that patients are only safe when staff are safe. It feels like a kind of theme that we've come back to at various points in this conversation today. Just before we finish, let me just encourage you, the audience, to share the link to this event with colleagues who you think might be interested. You can watch back on demand. It has been recorded. And also, please provide us with some feedback. We're always looking to improve these events. On the left-hand side, there's a menu where you can navigate to a feedback option, and you'll also receive an email with a very quick survey in it. Please, can I encourage you to fill it out? And finally, thank you again to our event sponsor, Spire. I'll leave you now to go and enjoy the rest of your day. Thanks again for giving us your time and your ears this lunchtime. Goodbye.